So good afternoon, everybody. Welcome to our June WebEx, part of our monthly SPSP Medicines WebEx series. It's great to have you all along, and you'll see by what you can see on your screen this afternoon that we're focusing on models of care, and we are really quite pleased to be having colleagues from NHS Grampian who are going to be sharing the way that pharmacy services are being provided across primary care to ensure the safe use of medicine. So we'll be hearing from Hayley and Sue very shortly. So just a point for our WebEx today. For those that aren't speaking and have joined as participants, your lines are currently muted, but we will look to open those at the end of the presentation to allow for some open discussion. And for those that have joined the WebEx and not yet able to join by phone, there's just a prompt there in terms of the participant PIN that you'll need to use to join. As I say, we are going to open the lines later on for question and answers, and we hope that you'll be able to participate in that. Then in the meantime, we're really keen that you do get involved via the chat box, and you can see that Arvind, our clinical lead for medicines, has already acknowledged, I think, a fairly average working day around managing people with their medicines, and it's great to have you there, Arvind. If we can ask each of you to introduce yourselves in the chat box, let us know what you do and where you work. And again, just out of interest, let us know what the temperature is where you are. We can see if we can have a competition by the end. The only comment I would say is please make sure that you select everyone from the top of the list when you use the chat box, and that would be absolutely fantastic. So in terms of moving forward, we are going to be recording this WebEx, and so for those people that aren't able to join us today, it's great that you're listening to the recording, and we hope that you enjoy it as much as we are in the live presence. So without too much further ado, it's probably important to acknowledge that we've got Lorraine and myself in the room today as part of the team, and Arvind is, I think, on site in Edinburgh dialing in. And we've also got a number of other people from the primary care team in the room with us today in the Guile, so it's great to have everybody here. But again, if you can use the chat box to introduce yourself, that would be fantastic. One point before we do move on, we're really keen to make sure that we make these WebEx series as, I guess, as relevant to those that dial in. And we did an evaluation, and a number of people provided feedback on our 17-18 WebEx series. And a couple of key points in terms of suggestions for future topics was really to look at how to attract more patient representatives and public partners to become involved. And I think the May WebEx we hosted last month really focused on how we can improve engagement using NHS Tayside as an example. There was an ask also to hear about pharmacists who have developed advanced practice. And while today may not be exactly advanced practice, I think it's a really good opportunity to hear about unique pharmacist roles across the healthcare system. And there was also an ask to focus on high-risk medicines. And a shameless plug that next month in July we're going to be focusing on insulin safety in acute care. So we're really important and value your feedback and how we can move forward. In terms of some progress and other things that we've been doing and making sure people are aware, we have published the Stakeholder Exchange Outcome Report, and that was published last month. And that's really given a structure in terms of how we are going to move forward with our work. And we've also released the Medicines Bulletin, our 10th Medicines Bulletin update. And for those who've not actually seen those, they're all available on our website. And I guess the only other thing we wanted to highlight too is the opportunity to share patient stories to provide useful learning around our country. And there's an easy-to-use template on our website as well to help describe patient stories, either when things have gone well related to medicines management or when things haven't gone so well and there's learning to be had. It'd be great if you, again, could go to the website and have a look at those. So it's fantastic, too. We can see people joining into the chat box and letting us know where they are. It's fantastic to see we've got people from Shetland, Elgin, people in Edinburgh. And it's fantastic that we've got such a broad range of folk in the room with us. So before we hand over to our presenters today from NHS Grampian, we thought we'd get an opportunity to see exactly who's on the WebEx in terms of what profession would describe you. So I'm going to hand over to Lorraine, who's going to administer our first polling question of the WebEx.
Thank you. Stopping the poll now.
So the polling question is, which of the following professions best describe you? And if you can pick from one of the 5 options, either a patient or a service user, medical, nursing, pharmacy, or other. And if you do select other, please do jump into the chat box and let us know your profession. So we'll be closing that poll very shortly. Okay, thank you all very much for doing that, and you'll hopefully see the results very shortly in the chat box. Excellent, and you can see there we've got a range of folk from patient service users, medical and pharmacy, as well as one other, and of people who have not yet chose to answer, and that's great. But thank you all very much. So without further ado, it's my absolute pleasure to introduce Hayley and Sue, who I'm sure they're going to give a better job than I will in terms of letting us know what they do and who they are. But again, really focusing on the different models of care to support safer use of medicines, and today really focusing on the primary care setting. So we'll now pass over to Hayley and Sue.
Thanks, David. So good afternoon, everyone. Thanks for having us. My name is Hayley Porter, and I'm a pharmacist working in primary care in NHS Grampian. So my official title is a GP clinical pharmacist, and I'm joined by one of my colleagues, Sue, today, who is a primary care pharmacy technician in Grampian. So, as David said, we've been asked to talk about models of care today. So I plan to tell you just a bit about the work I've been doing in the GP practice, so just a sort of broad overview of my role in the practice, and then a bit more of a focus on some improvement work that we've been doing recently around medicines reconciliation. And then I'll hand over to Sue, who is going to talk a bit more about her role within primary care. So if we could go to the next slide. Oh no, yeah, we're on the slide, that's fine. So a bit about me just to start with. I qualified as a pharmacist in 2010 and spent 5 years in community pharmacy before moving into primary care. And I became an independent prescriber in 2016. My initial post in primary care was through the Prescription for Excellence work. And we had quite a big focus at that time on polypharmacy reviews, and I worked across several GP practices in the city. I then moved on to a full-time post within a single medical practice, and they were one of the first within Grampian to sort of trial a new model of primary care. And this sort of came about due to a sudden closure of one of the practices in the city as a result of GP shortages. So a new practice had to be set up at relatively short notice, and they addressed the GP shortage by having an increased focus on other healthcare professionals taking on extended roles within the team. So that particular practice actually had 2 full-time pharmacists, as well as 3 advanced nurse practitioners and 2 physicians associates. So it was quite a new model involving a multidisciplinary team. And it was a really fantastic opportunity because we basically had a blank canvas to build and develop the roles, which was quite a unique opportunity really, and it did work really well. So from there I then moved on to my current post in my current practice, and it was really good because I was able to use the skills and experience that I'd gained to develop the GP clinical pharmacist role there. So if we could go to the next slide, please. So just a wee bit about the practice I work in. So it's a city centre practice with about 7,000 patients. It's a relatively affluent area, but there is still quite a mixed demographic there. And it is probably what you would call quite a traditional team. Prior to my appointment, the practice had input from a health board pharmacist just 1 day a week. But with funding from the Primary Care Modernisation Fund, the practice decided to directly employ another pharmacist, which is me, for 30 hours a week. So I'm actually there 4 full days a week. So they were one of the first practices in the city to employ a pharmacist for such a substantial number of hours. We found a lot of practices were waiting until they were really feeling the strain of GP shortages before they would consider a pharmacist. But in this case, the practice were quite forward-thinking, and they employed me despite having adequate GP cover at the time. So I did find that was a real advantage because we weren't really in that sort of firefighting situation where the practice was already on the brink of a crisis. It's quite a stable practice, so it allowed us to really plan and sort of tailor the role to the needs of the practice. And that sort of maximised input I could have, really. And of course, it's always, the role's sort of continuously developing all the time as well. So next slide, please. So this slide just gives a sort of overview of the main tasks that I undertake in the practice. The practice pharmacist role itself is not really a new thing, but having sort of 30 dedicated hours to a single practice has sort of significantly expanded the role and extended what I'm able to do within the practice. And I'd say that one thing is that there's just much better continuity and consolidation of the work that I'm doing in the practice. As you can see, it's quite a varied role. There's sort of a mix of patient-facing stuff and sort of more behind-the-scenes type work, but it's all quite clinically focused. So next slide, please. So just have a look at the sort of polypharmacy work that I've been doing. I think it's well known that a huge number of hospital admissions are due to adverse drug reactions, and you can see here that 50% of those are seen as preventable, and 70% of those are actually in patients over the age of 65 on 5 or more medications. So there is a huge opportunity to improve on this and improve patient safety, and one of the ways to do that is through polypharmacy review. So I run a weekly clinic in the practice where I see patients for polypharmacy reviews, and we also have a monthly multidisciplinary team meeting where the practice-linked geriatrician comes along and we discuss and review polypharmacy cases. And then I'm then responsible for following up those recommendations with the patients themselves. So I do that either in my clinic, invite patients in for a face-to-face review, or I do try and go and visit them at home if they are housebound patients. So we did sort of identify within the practice that for housebound patients, you know, the sort of more routine medication reviews and chronic disease reviews were perhaps not as good as they could be. Generally, patients would just be seen if they were acutely unwell by the GPs. So myself and one of the advanced nurse practitioners had started to try and more routinely go out and see these patients in their own homes so that, you know, they weren't missing out on the service. And next slide, please. So just as a bit of a summary of that work, from April 2017 to March 2018, we did 102 polypharmacy reviews, and the recommendations that came from them included 186 medicines being stopped, 49 doses reduced, 28 medicines switched to more suitable alternatives, either clinically or in terms of cost effectiveness, 11 medicines being started and 3 doses being increased. So this had a really positive impact on the patients, you know, reducing their tablet burden and reducing the risk of adverse drug events. And I also found that quite often other issues would come to light during the reviews as well, which were maybe kind of bubbling away under the radar before. So for some reason, patients would quite often like to divulge information that they had not told the GP before. And just a couple of examples. So a recent one was a patient who, usually when I see patients, I'll ask them to sort of talk me through how they manage their medicines and what their kind of daily routine would be. And he informed me that he just took all his tablets first thing in the morning, because that was the way it fit with his routine and that's the only way he would remember to take them. So on further discussion, it transpired this also included his simvastatin, which should have been taken at night, and also all of his metformin tablets, which should have been in divided doses with each of his meals. So it turned out he'd never bothered to mention this to anyone before because nobody had ever really asked. But now that we had that information, I was able to sort of alter his medication regime to fit with his own routine and sort of provide a more patient-centred care for him. Another example was a home visit I did recently to an elderly patient who was prescribed tramadol. So when I'd asked him about how he used his tramadol, he informed me that he didn't actually take it because it made him quite constipated and nauseous. So I was quite surprised by that because when I'd looked at the computer system before I left, he was ordering it on a regular basis. But he then proceeded to show me a full drawer in his chest of drawers in his bedroom, absolutely packed full of tramadol to the brim. And it turned out he used one of the local community pharmacies who offered a repeat prescription ordering service. So he'd been getting a box every single month along with his Dorset box, despite not actually taking it. So he was quite happy for me to remove the medication from the house because he had no intention of taking it. And when I counted up the capsules, there was actually 2,209 tramadol capsules that had been in this drawer. So that is obviously a huge patient safety issue and also a substantial waste as well. So we were able to get that sorted out with the pharmacy, and hopefully there's not too many other instances of that across the city, but it wasn't a good one. So if we could go to the next slide, please. So another large aspect of my work is around medicines reconciliation. Obviously, MedRec is important for any transition between care settings because it's a high-risk time for medication and prescribing errors. So in terms of transition from secondary care to primary care, I'm responsible for completing the MedRec for all immediate discharge letters that come into the practice. So we get roughly about 130 a month. So that obviously saves significant GP time. And I'm able to take the time to do a thorough MedRec and follow up on any queries or discrepancies that come to light with the secondary care team. And I will then liaise with the patient and the community pharmacy, for example, if the patient's on a Dorset box, and also quite often our primary care pharmacy technician team, just to ensure that there is effective seamless care. A recent example was a case where prior to admission there was a lady, an elderly lady, who was on a Dorset box, and she had a care package in place for carers to sort of prompt and assist her with her medication. But then on discharge, the letter stated that she was now on original packs with MAR charts and the carers would be administering her medication. So a few days after she got home, it actually came to light that the care manager hadn't been informed of the change. So there was a discrepancy between, what was intended and the level of care the patient had actually been commissioned for. So it actually resulted in omission of her medication for a couple of days because the care package didn't allow the carers to administer the medication, and the lady wasn't able to manage the original packs on her own. So I was able to liaise with Sue, who's my colleague that's here today, to try and get this sorted out. And the real advantage of our pharmacy techs is that they have really strong links with the care managers and the care providers and the social teams, so that she was able to report that to the correct person and get it dealt with and rectified really very quickly. So they did a full assessment of the patient again and actually decided that there wasn't really a need for her care to be increased, and that she was actually fine on the original system with the Dorset box and the prompt and assist from our carers. So that was able to be sorted out. But I think that shows it's sort of another side to the MedRec process, in that it's not just about the drugs and the medication changes themselves, but also about how they're actually being managed and how the patient's administering them once they get home. And it does highlight the importance of a multidisciplinary team approach, and also, having the strong communication links in place. For the clinic letters, so I'm also responsible for actioning any clinic letters that come in from, secondary care or outpatient clinics, anything that involves initiation or discontinuation or alteration of medication, which again saves the GPs quite significant time. So I'll make a record in the patient's notes, prepare the prescriptions, update the repeat list when appropriate, and I'll liaise with the patient or the community pharmacy as and when needed. And I think my role here does have quite a significant contribution to patient safety, for example, with things like DMARDs, where you've got quite high-risk medications being started or stopped. So I think it's really important to speak with the patient in these cases and make sure that they're aware of the type of medication and the risks associated with it and the monitoring and things that's required. Because quite often it might be a couple of weeks since they were actually at the clinic. So they might have forgotten a lot of the information they were given, or they might have thought of more questions that they didn't ask at the time. So I think it is quite useful for them to make contact with them and allow them to ask those questions. And next slide, please. So when we talk about medicines reconciliation, I think we quite often go straight to the secondary care to primary care transition for patients. But another aspect that we've been working on in the practice is for patients that are transitioning within primary care, so when they're moving from one GP practice to another. So we decided to look at how repeat medications were being added to the prescribing system when a new patient joins the practice. And we really wanted to look at this and try and standardise how this was being done so that it was a bit more consistent within the practice. Of course, this would improve patient access to their medication, and also it means that the information is available on the emergency care summary in a more timely manner, which improves patient care and safety if they're then being seen by out of hours or if they get admitted to hospital. So it's essential that the emergency care summary is accurate and up to date for accurate med rec when they go into secondary care. So that needs to come from primary care in the first place. And next slide, please. So the first thing we did is we had a multidisciplinary meeting with the whole practice team, and we created a process map of the existing process. So this is obviously quite a busy slide, but you can maybe go back and look at it later if you want to on the website. But the main issue that we found was that there wasn't really any consistent process in the practice for dealing with new patients that were on repeat medication. The admin staff didn't really provide any guidance to new patients on how to access their prescriptions when they were joining the practice, so it was very variable for how prescriptions were being requested and issued. So some patients would come in to see the GP for an appointment, some would just leave a request on the prescription ordering line, and some were actually also ending up on the duty doctor triage list, which is really not ideal. So next slide, please. So we then produced a driver diagram, and we set our aim as 95% of patients would have their repeat medication recorded on Vision, which is the prescribing system, and therefore available on the emergency care summary within 4 weeks of registering at the practice. And you can see there that we've identified our primary and secondary drivers as well. So to achieve this, we decided that the new system would be reception staff would sort of screen the registration forms at the time of registration, and if the patient had indicated that they were on any medications, the form would then be passed to myself, and I would wait on the electronic record coming in from the patient's previous surgery, and then complete a med rec and set up the repeat prescriptions where appropriate. So next slide, please. So just to give you a bit of an idea of the impact this had, we did a bit of sort of basic data collection. So you can see here, this is the percentage of patients with their repeat prescriptions added to the system within 28 days of registering. So the November 2016 is before we started the project. So there was 47% were on the system within the 4 weeks. And then following implementation of the new process, the figure increased to 92% in the March 2017. And then when we looked again in the November, it was up to 100%. So that was quite an improvement that we've seen there. And next slide, please. So we'd also looked at how the repeats were being added to the system as well. So this is prior to the change, so in the November of 2016. So 47% of cases were actioned at a GP appointment, and 26% were through the patient requesting an acute prescription. And then if we go to the next slide, thank you. So when we compared this to the March 2017, which was after we'd started the new process, there's just 23% of cases that were dealt with at a GP appointment, and the other 77% were dealt with by myself doing a planned med rec. And there was none that had ended up on the acute prescription request screen. So that showed quite a difference, and it obviously saved quite a few GP appointments as well, which was good. And then the next slide, please. So then when we moved on to the November 2017, so for this month it was quite interesting actually, it was equal numbers, so 44% of patients saw a GP for their repeats, and then 44% were dealt with by myself, and then there was a small number that had ended up on the acute prescription requests. So when I looked into that a bit further, half of the patients that had been seen by the GP could actually have been dealt with by myself, but it turned out the patients had actually booked appointments within the first 7 days of registering at the practice, so that was before I'd had a chance to do the MedRec. So this highlighted a need to review, what reception staff were telling patients at the point of registration so that we could try and tighten it up a bit more and avoid unnecessary GP appointments. Of course, you're not going to be able to remove that completely because some patients do just want to get straight in and meet their new GP, or they may not have had a prescription to tide them over from their previous practice, so it's a bit more urgent. And the next slide, please. So just as a bit of an aside, something else that we'd looked at as part of the project was ensuring that any drug allergies the patient had were recorded on the system as well when they joined the practice. So when we had a look at that, so in the November 2016, it was just 16% that were accurately recorded on the system. By the March in 2017, it was 66%, and then by the November, it had increased up to 81%. So this obviously still needs further improvement, so we're working on that at the moment, but that's quite a significant patient safety issue as well, if people's drug allergies are not accurately recorded. And hopefully in the future it might be something that will happen automatically if there's better transition of the information, a direct transfer of the electronic notes, but at the moment that does have to be done manually, so that's something else that we've been looking at as well. But overall the project has been very successful. I think it does demonstrate another important aspect of medicines reconciliation, which can be done by a practice pharmacist, to improve patient safety and also save GP time. And next slide, please. So just as a bit of a summary, so I've been in the post now for just over 18 months, and I really do thoroughly enjoy my job, and I do feel very valued within the team. And this is just a couple of quotes that we've had from some of the GPs in the practice, just about the role and having me as part of the team, which are obviously very positive and really nice to hear. And then next slide, just to finish off, I just want to sort of do a wee summary of the benefits that I see from the role. So there's the benefits to myself, so it's quite a clinical role, which is definitely where my sort of passion in pharmacy lies. I do feel like I'd have much more of a direct impact on patient care, and do feel very valued within the team, and there is a huge potential for professional development within the role as well going forward. It's already changed considerably in that first 18 months, and I do feel very enthusiastic that we can keep sort of growing the role going forward as well. Benefits to patients, so there's increased patient safety, increased availability of the GPs since they've got more time, and improved access to care in terms of medicines related issues and queries, because they know that they can phone the practice and actually ask to speak to me directly if there's any medication related issues, which seems to work very well. And then benefits to the practice, so there's increased clinical capacity within the team, and improved access to advice on pharmaceutical care, and also reduced GP workload. So I think that is my section done. So I'll pass you over to Sue now so she can tell you a bit about her role.
Just doing a bit of changing of chairs here to get comfy. Hi folks, my name's Sue Eddowes. I'm a primary care pharmacy technician with NHS Grampian. So on the screen just now we've got really just a bit of a summary of the presentation I'm going to give you, and a definition of care at home for those folk who are not familiar with care at home. So supporting patients living in their own home who receive local authority commissioned care. So if I can have the next slide, please. Okay, just going to get my own notes up here. So in 2008, so going back 10 years, I joined the primary care team. Initially, my role was one of 2 pharmacy technicians, we still have 2 in post, who provide support and advice to staff in care homes. So I had 18 out of the 37 city care homes. This new job was primarily to ensure robust systems for medicines management were in place in the care homes and to check that staff in the homes followed national and local guidance for processes such as ordering, receipt, storage and return of medication. Another aim was really to try and minimise waste of medicines as far as possible. This work was centred around supporting the staff in the homes with these routine tasks, and unfortunately, looking back now, at that time there was very little or no patient contact at all. So 1 year on from this, 10 extra hours became available to support care staff and patients. This was in an intermediate care unit called Smithfield Court Project. It had been on the go for many years, but had still remained project as part of the title. But the best way to describe this really was a unit that provided a step down from hospital, or in fact a step up from home if someone needed more care and a bit of assessment of their abilities. So for me, this really changed things. I became part of a multidisciplinary team, small team, but albeit a multidisciplinary one. So the slide itself lists some of the healthcare professionals involved. So, you know, as you can see, I'm not going to rattle them off, but quite a wide range of different healthcare professionals that I was now part of the team with. So another bonus was, for me, I had contact with patients. Slightly frightening to start off with, getting into that sort of domain of visiting and chatting one-to-one, but my real first introduction to face-to-face patient contact. So love it now, but the time was a little bit daunting. So at Smithfield, one significant thing I did was roll out proper MAR charts. The staff had actually been using what I would describe as like an ABC type of recording sheet, so a bit like a hospital Cardex, where very, very difficult to audit the medicines that the residents or clients had been given were correct. So there was some resistance from the carers to start off with, but this was in early days, and they settled on into it and moved on to the system, which is now widespread across the city. Self-medication was encouraged where it was safe to do so, and we use self-med charts at Smithfield. Next slide, please. So this image represents integrated pharmaceutical care from the Scottish Government document Achieving Excellence in Pharmaceutical Care. I think it's really good because it kind of shows our role. I mean, the diagram itself shows how the pharmacy services link together, and each of the circles gives a summary of the services provided. But I kind of think we're actually right in the middle. If I could draw a little stick person, we'd be right in the middle, moving around between the three different sort of areas there, and in fact wider field. So to do this, we do need to have a good understanding of most, if not all, of what each arm of pharmacy does. Next slide, please. So this slide is the sort of pathway of our referrals, really, from the start to where we are now. So in January 2017, our care at home referrals started off, mostly coming from our colleagues in the hospitals. So these referrals were for people who were due to be discharged home, who had been identified during their hospital stay as needing some sort of support with their medications. So in April 2017, our own joint health and social care medication support service guidance for adult services was updated, and so as well as getting referrals from hospital pharmacists, we actually began taking referrals from care managers, care coordinators, who are both community-based and hospital-based, but also from the companies that provide the care. So during this time, we also started getting general queries from practice pharmacists, community pharmacists, district nurses, very sheltered housing staff, and in fact quite recently a query stroke referral from an OT. So we'll do our best to accommodate these requests, but we are, because there are just the two of us doing this care at home work, we're rather limited, so we have to be a bit careful about our workload. We certainly try and help out as far as we can. Next slide, please. So we've got a diagram here of really just the kind of nitty-gritty of what we do in a home visit. I mean, I suppose lots of things, and it doesn't have to be just one at a time. Everything tends to overlap, but some of the sort of main kind of groups together are things such as looking at compliance. So we look at, you know, can the patient or client pop out the tablets? Can they read the labels? Can they actually understand the instructions? You know, looking at the label and checking their understanding is a must. If they are self-medicating, but also just good to do so, check what they know about the medication. We often need to do some level of meds rec to ensure the patient's taking the right medication. So this may involve actually removing all the medication no longer required from the patient's home after consent has been received to do so, especially where they've had lots of changes to medication on discharge from hospital. So if there had been changes, we would certainly talk this over with the patient and really just to explain things and try to reduce any confusion they may have about the changes. We might do a chart, sort of something like a self-med chart, or even just an explanatory chart, just for a visual guide, really, more than anything else, just so they could see chronologically what they take and when. So we'd always try to do a follow-up visit where there's uncertainty of how the patient would manage the medicines. So certainly for referred patients who've had a readmission and then subsequent discharge, we would revisit, and if we wanted to check compliance over a period of time. Next slide, please. I'm not going to go through all of these, just really a list of some of the possible interventions that we have done, more than, well, generally it'll be more than one at a time during our visits, but I won't rattle through them, but you can see it's a fair range of interventions that we offer as part of our care at home service. And you could have the next slide, please. So, we've just gone blank on the screen here, but I've got my slides in front of me, so I'll crack on. The first slide here is an example of a care management referral. So this is a referral I took on. This is for a care home resident who was soon to be discharged to sheltered housing. He no longer needed to be in a nursing home, and obviously, you know, lack of space in the nursing homes dictates if somebody didn't need that level of care, just like anywhere else, to be reassessed, and this gentleman was suitable to be discharged. So his care manager wanted to know what options were available for this gentleman's medicines. He'd been in the care home for about 4 years, and during this time he'd had his medicines administered to him by the nurses. So he himself hadn't dealt with his own meds for a long time. He had capacity, and the hope was that after discharge he would become more independent, which raised the question about how to get him to this stage of independence. So we started off wondering if the care home would actually be able to get the gentleman started with self-medicating. Unfortunately, due to safety concerns with other residents, they said no to this. It is understandable, they have to look after everybody, but in the circumstances we didn't get a chance to try out self-med prior to discharge from the care home. So we'd need to ensure the meds were safe for the new tenancy in sheltered housing. We decided that really MAR charts and original packs would have to remain in place. The care staff would be commissioned to administer his medication. In Aberdeen City, we would call this grade 3 medication administration. The man's got capacity, but he needs his medicines administered and MAR charts in place. So once the gentleman had settled in, we got together to revisit the arrangements and look at ways to get him more involved with the process. Could I have the next slide, please? So on the day of discharge, I helped with moving his medicines from the care home to his sheltered housing flat. So the staff were more used to using the compliance aids, so weekly packs, blister packs. So it was really important to make sure, I wanted to make sure the MAR charts and the medicines were absolutely spot on. Everything was in place. I wanted to check the care staff were happy with everything. I gave them my details of point of contact, so if they needed to get in touch, they could do so. So after discharge to his new flat, over the next 3 weeks or so, I did do regular checks, not necessarily with him every time, but just checking up how were things going with the staff, and it became really clear he was settling in extremely well and was in fact very capable of doing more for himself. So the care staff were getting involved with things, and he was actually happy to do so. The care manager and I met, and between us we decided to actually, for the moment, leave the MAR charts in place for 1 further month until she had done her 6-week review. So we were hoping to move this gentleman on to weekly dispensed packs at this point. And the carers would be able to supervise him to start off with, and the plan would be to reduce input if they could do so. So after the care manager's review, she gave the thumbs up, and I liaised with the practice pharmacist. We got the scripts adjusted, liaised with the community pharmacy about a start date and packing his medicines. The first pack was delivered the following week, and so this is about 7, maybe 8 weeks down the line, and the pharmacy removed the medication that were now in the weekly pack, and after checking about a month after that, everything was going really, really well. So at that point, I was able to close off the referral. And if we could have the next slide, please. So this slide, it's just one slide here, and I'll try to keep the time quite good with this one. I'll whiz through. It's an example of a hospital pharmacist referral. So a ward pharmacist got in touch with us to refer a gentleman who was due home from hospital. He'd been readmitted 18 days after the first discharge. During his readmission, the ward doctor had seen that he'd missed some doses, and wondered whether there was a possible ordering issue, had some thoughts about whether the patient was confused about his medication, and had wanted to start him off with a compliance aid. And the ward pharmacist didn't actually think this was needed, and the patient had never had one before, so she was very conscious of the fact that you know, it'd be good to try not to change things, bearing in mind he'd only get a week's supply on discharge, but she knew about our service, so she got in touch and agreed to visit. I agreed to visit him the day after discharge to have a chat to see how he did his ordering. I also wanted to have a look at his compliance. So before discharge, the pharmacist agreed to aim for a 28-day supply of his medication, really just to align things all to the same duration. We would, I did a tidy out of his medication just to make sure there was nothing remaining at home. Everything was starting off at the same time, and everything was the same duration. But at my visit, I was actually really pleased. The gentleman was indeed very organised with his medication. He had his meds all laid out on the table with his discharge letter. Maybe he knew it was coming, but he certainly was very organised with things. And he actually knew what he was doing and didn't have any problems with reading labels, popping things out. So on discussion about the blip before admission and the possible missing of doses, we established what had actually happened. So the gentleman had actually requested some furosemide a couple of days before his existing supply had run out. This was a repeat script, which was run off with the practice staff and put to the GP for signing. He didn't have a nominated pharmacy set up, so the script was retained at the GP practice awaiting collection. His daughter had gone round to collect a script, but not knowing what it was for, took the script that she picked up to the pharmacy. It turned out actually it was for something else, and the gentleman, on receipt of the other medication, I think he actually assumed that the doctor had intended for him not to get any further supply. He didn't question it. He just accepted that. Now, he'd actually missed 4 doses of 80 milligrams of furosemide. So 4 days and 4 missed doses, he was readmitted to hospital. So on my visit, we actually talked about simple things, but things like placing regular orders for medicines. I suggested he ordered it at least 7 days before running out. And we sorted out the paperwork to ensure that his scripts went directly from his GP to his pharmacy, and explained how all that would work. One last thing before I left was the patient actually said he'd been taking some other medication he bought from a supermarket and wanted to check if this was okay. So looking at the patient information leaflet, I saw the advice was that he shouldn't take these unless recommended by his GP, but I said I'd check with the pharmacy. The pharmacist checked, and I gave him a call to advise him not to take these. I suggested he spoke to his GP about his symptoms, and gave him a call about 3 weeks later, and he just placed an order on time. Everything was going fine. So, in fact, at that point, no further visits were required. And final slide, if I could have that, please. I think this slide, I'll just be really quick here, I'm conscious of time. I think this slide really sums up our care at home work quite well. Shared decision-making and personalised approach to care. We involve the patient and find out what will work for them. We hope to identify any areas that could cause medicine-related harm, and we would try to reduce waste by encouraging people to use the medicines properly. Unnecessary variation practice, we follow the medication support guidance, so things are kept consistent. We encourage enablement, so managing risk better. So sometimes this needs a leap of faith, but it's worth it to allow patients to maximise their independence. And certainly for innovation and improvement, the first in Aberdeen, so we're definitely innovators. No doubt we've improved care of patients who've significant changes to the care aspect of the medicine setup, and certainly for those who have moved between health settings. Thanks, that's me finished now. Sorry if I've gone over time there. Back over to you guys.
Thanks, Sue. Thank you very much, Sue and Hayley. And it's really, again, an opportunity for us to hear one example around how primary care are shaping services around ensuring safe use of medicines. And again, we're using today with an example of a GP, pharmacist and a technician working within the care and home settings. So thank you very, very much. I really am keen that we've got some time for questions before we bring the WebEx to a close. And there has been, and I hope you've seen, Sue and Hayley, there's been a lot of chat, a lot of comment that we're really keen to pick up bits for. So if we can probably go back, Hayley, starting with you, to paraphrase a little bit, there's been a few questions around metrics and impact, and I think we kind of predicted this might be some of the discussion coming through today. One of the questions was around any data that sort of demonstrates GP's time and what did they actually do in the time that was being released to them back. Is that something that you're able to comment on?
I don't actually have any specific data as such around that, although I'm aware that that would be a very valuable thing to try and pin down. One of the things was, I do know, is when they employed me, one of the GPs had actually left the practice and they didn't fully replace all of those hours. So I think part of the deal was, you know, they were taking on a pharmacist for 4 full days, and that was kind of replacing some of the time that, you know, that GP for him leaving, instead of replacing that fully, I was taking on part of that workload. So there wasn't like a huge, I'm not aware of there being a huge number of extra appointments added on or anything like that. I think quite a bit of it was that transition, but it's something I'm going to look at further with the practice manager and see.
Your line has been unmuted.
The impact, because I think it's quite a tricky thing to quantify, because especially the number of tasks I do, that there's not a consistent time frame you can put on each task. You know, it can be really variable. But it'd be quite interesting if anybody else is doing something similar. I would be really keen to know how they have managed to kind of evaluate it in a quantitative way.
Thank you very much for that. Gordon, who's in the room with us, has got a question as well for you. And can I just, before Gordon asks his question, all of the lines have been unmuted, so we're really keen to sort of have some dialogue with those that have joined the WebEx today. But Gordon.
Yeah, it's Gordon Black here. I'm a GP in Edinburgh. clinical lead in healthcare improvement in Scotland. I suppose we have a pharmacist in our practice who's collating some data around the metrics of the impact. Go back to the question, what do we do with that extra time? We finished last night with 3 of us were in the practice at 7:30. We finish now at 7:30 rather than 8:30. So it's saving us time to go home and have a better balance of life. But I suppose we have some measures we're looking at. Are you comparing with any other local pharmacists in Aberdeen, for example, Aberdeen City or wider? What other metrics they're measuring? Do you compare what your role is with other pharmacists across the local area?
Yeah, I would say to be honest, I've not done any direct comparisons myself. I think it's quite variable at the moment with the time each practice, well, there's only certain practices that have actually employed a pharmacist, and it's quite variable. Most of them aren't as many hours as I do, and obviously each practice is kind of different and with their list size and things as well. But I do think that would be something that would be useful for the future, just to compare. I mean, I also work, my 5th day a week basically is still with the Health and Social Care Partnership team. So there are quite a few of us that do the dual roles. So I do speak to them kind of informally, I guess, to compare what we're doing and the different types of tasks and things. But in a formal manner, no at the moment would be the answer.
Just come back, we're happy to share. We have a spreadsheet that our pharmacists are using locally. Happy to share that. So it's just really collecting what data is available. Yeah. It doesn't really show it's really activity data rather than impact. So we'd have to think a bit more about that. Another quick question. I don't want to hog the questions. Quick question about cross cover and your employment. So you're employed by the practice, so rather than the partnership. So if you're not around, if you go on holiday, what happens in that situation?
So at the moment, they kind of just have to get on with it. Yeah, like you said, they still have their health board pharmacist 1 day a week. So she is there. She can sort of pick up some of the workload, but obviously that's limited because she's just there 1 day. But otherwise, yeah, I just try and give plenty warning for when I'm not going to be there. And the GPs do just have to sort of, like you're saying, they might just have to stay a bit later for that week or so to try and pick up the workload. Because yeah, at the moment there's not really the resource to cover it. You know, that would have to come from within their own funding. So yeah, there's no cover at the moment, unfortunately.
And just one last thing about patient experience. What feedback, if any, have you had about patient experience with engaging with patients directly or helping with the pharmacy? What sort of feedback have you had from them?
Yeah, I would say generally very positive. I think, especially the polypharmacy reviews, the patients really do seem to like that, and they're very keen to come in for reviews. And you know, we try and invite people in. I kind of do searches based on date of birth or whatever. So you might invite somebody's husband, and then the wife knows, and she's like, "Oh, why have I not been invited? Can I come in?" And they all seem very, very keen to come in and have the reviews. And there's been quite a few comments that they really value the time with somebody. You know, again, they're quite often might only come to the surgery if they're acutely unwell, so I think they really value being seen just for a general review and to, you know, discuss all their medication on a whole, and they feel a bit more comfortable that they can spend that time with me and ask lots of questions. I think sometimes as well they're a bit anxious that they don't want to waste the GP's time, but and also I always make sure I tell people that I'm available over the phone as well. So I'll quite often take a lot of queries each day from patients that maybe just have a quick question about their medication, which they might have had to wait a while to see the doctor. So that does seem to work really well. And I would say community pharmacy-wise as well, there's been really good feedback from all the local community pharmacies, because that can be quite a good link for them to the practice for queries as well, which saves the GPs having to deal with them.
Thanks, Hayley. And can I check that the lines are open, and we've probably got time for maybe one or two final questions. What questions do you have for Sue and Hayley this afternoon? Well, Sue, I know that we had the privilege of meeting each other a couple of weekends ago at the UK Pharmacy Technicians Conference. I'm just curious about how much of your role you might know is replicated in other partnerships. How far widespread is the pharmacy tech role in the home care setting that you're aware of?
Are we talking in different NHS areas?
Well, particularly in your local patch, I guess, in the first instance.
There's just the two of us in the city. Out with Aberdeen City, it's such a wide area. Aberdeenshire is really big, huge sort of mileage needed to cover that. So there are no pharmacy technicians doing this sort of service in Aberdeenshire. I think the nearest to us would be Tayside. I was very fortunate to meet some at the conference. So we're creating links between ourselves and the other NHS areas that do have care at home, just to try and share, really. But certainly directly next to us, two in the city, which is myself and Audrey, and the next sort of place is Tayside, really. So it's innovative for Aberdeen City anyway. So.
Absolutely, and I guess one of the things I took away from the conference is there is a variation across how services are being set up and delivered, not just across Scotland, but across the UK.
That's right.
So can I thank you both for your time in terms of delivering what is your model of care, and I really want to stress that this is an example. We know that there is a very broad variation in terms of how care is being provided. And one of the things to flag up to people that we are going to be hearing from another board later in the year in the WebEx series in terms of how primary care services around have been set up, particularly within another board. So we're keen to sort of continue the theme of sharing models of care, and we're going to pepper that throughout the remainder of the year. So without further ado, I just want to comment again on the fact that we are focusing on the 6 levers or drivers that were identified in our stakeholder engagement, and we're committed to making sure that all of the work that's shared and how we move forward is focusing on the fundamentals of patient empowerment, education, QI support, work processes, which again I think today is around those models of care, recognising excellence, and also the use of technology. So we're really keen that those are the core themes that we bring through all of our work moving forward. So our schedule, we have got confirmed right through until the end of March now, which is available on our website. I've mentioned previously that the July WebEx is going to be focusing on insulin safety. And then we're moving to hear from Northern Ireland in August, and they're going to be providing, again, some examples of how they're using supervision to support safer prescribing. And there's going to be 2 examples of that from the Northern Ireland model. And in September, we're going to be hearing from the SPSP medicines team, again, continuing on the theme of high-risk medicines, but looking at some early data around bleeds associated with medicines use. And we're really keen to get people's reflections and ideas on how we could use that kind of data. So we thank you for joining us today, and we really look forward to having your company and sharing with others on the 19th of July, when we're going to hear about insulin safety in acute care settings. So thank you all for your time, and again, I'm sure you're very appreciative of Sue and Hayley's time today. Thank you very much.
Thank you.
Thank you.